Well, again, I'd like to begin by thanking the organizers of the Congress and for the opportunity to be part of this terrific meeting with leaders from all over Latin America and the world presenting, and I'm very humbled to be asked to be part of this. So this talk is a little bit funny in some ways because I'm sure the practice of ultrasound for reflux differs in geographic areas in different countries and different cultures. So I'm going to talk about what I think is important in the examination and give some perspectives from where I come from. They may not be completely applicable to everybody's area. So this is who I am. I'm the same. This is the same as I was at my last talk. So what I'd like to cover are the following things. Talk a little bit about some anatomic and pathologic considerations, the components of the exam, the decisions that you have to make in designing your examination for reflux, training and communication, and then some things about compliance and standards. And credentialing and accreditation is a big thing in the United States, and those kind of standards I think can be very helpful in all settings, but naturally they're different in different locations. So this is a scheme that came out from the Society of Vascular Medicine in the United States. It's not current, about 10 years old, but shows a brief way of how you would consider dealing with the patient who has chronic venous insufficiency. So patients present with a swollen leg or an ulcer or something like that. They would be treated, probably have a diagnostic ultrasound to make sure they don't have an acute venous thrombosis, and then be treated with conservative therapy. If they get better, that's great. If they don't, then they go down a diagnostic pathway for further evaluation. This is just a blow-up of part of that schema, and non-invasive testing. And here, we're only going to talk about duplex ultrasound here. And the duplex may identify obstruction, in which case venography and interventions on the central veins or the axial veins may be useful. If reflux is identified, then we have to identify where it's coming from and consider the treatments. You can see that this slide is a little dated because it has consider valve reconstruction. I think everywhere around the world we've abandoned valve reconstruction because it simply does not work. So in these cases, particularly patients with refractory ulceration who, where the superficial disease has been treated and perforator disease may be treated, but they still have swelling and ulcers, phlebography, intravascular ultrasound can be very useful in identifying an obstructive component that augments and exacerbates the reflux that's also present in these patients. So there can still be a role for further evaluation, but not as part of this talk. I think the nomenclature of the superficial veins has been clarified. This is not a new development, but certainly in the United States, I encounter many people who still use the eponymic descriptions of various perforator veins. And I think the elimination of eponyms has been a big step forward in having people understand what you're talking about when you speak. And knowledge of the anatomy is very important, and particularly in the variations that you may see. I'll talk a little bit more about the location of the perforators a little later on. I think everybody's familiar with normal valve function and how reflux occurs, but this little cartoon I think is helpful. So normally what happens in this area of the diagram, the left side here, with the compression of the calf muscle, the flow goes towards the heart through the vein. The valve is opened. When the muscle relaxes, gravity or just the situation with the vein produces flow in an opposite direction that closes the valve and prevents reflux. When the valve is incompetent, flow can go through the valve, and generally that flow has higher volume than we would see in what's necessary to close a competent valve. And over time, the vein will dilate distal to that due to pressure. And this produces the distension, dilation, pain, the symptoms that we see in patients with chronic venous disease. Some important things for diagnosis that we need to consider is that the speed of valve closure really depends on the force of that reverse flow. And so when we try to assess the competency of valves, we have to make sure that we're providing an actual realistic physiological stimulus to valve closure. And if there's insufficient force, the valve leaflets may not close, not because they're incompetent, but because you haven't given an appropriate stimulus. And of course, the natural stimulus is gravity in the standing position. So one of the most important things when we do duplex ultrasound for reflux is identifying where the reflux is coming from. And this is a terrific paper, an enormous study of over 2,000 legs, mapping to look for reflux in various locations. This was from a group in Spain. Again, not recent, but I don't think anyone's going to repeat this study anytime soon. Obviously, an enormous amount of work went into producing it. But there's a number of things that I think are important to tuck in your memory and think about as you do these examinations. In these patients with reflux in the great saphenous vein, that was finding in about 2/3 of patients, only about half of those patients had reflux at the saphenofemoral junction. The rest had reflux somewhere along the great saphenous vein. So great saphenous reflux does not absolutely depend on the presence of reflux at the saphenofemoral junction. Reflux at the saphenopopliteal junction, seen in about 11% of patients, and virtually everyone who had small saphenous reflux had demonstrated reflux at the saphenopopliteal junction. So that's an important thing to remember. And then perforator reflux was noted at various locations, but one of the prime locations is in the thigh, and that was in almost 10% of patients. So remembering these things, I think, will help the investigator determine what are important components of an examination for reflux. So what do we want to do when we study the veins for venous incompetence in the legs? So we want to examine the deep veins, we want to examine superficial veins and perforator veins. And as you can see, this is a very comprehensive examination, and this examination takes quite a bit of time, effort, and knowledge. So when we talk about the technique that's involved, I think probably one of the most important parts of the technique is scheduling enough time. Trying to do one of these comprehensive examinations well in 20 minutes is impossible, in my view, even with an experienced, well-educated examiner. You'll have to be prepared to use multiple different probes because there will be veins that are quite superficial and others in many of the patients I see who often are obese, veins that are quite deep. Both the patient and the examiner need to be comfortable, and to do accurate examinations, as we'll show, you'd like to have the patient standing. That can be a problem for some patients. I'll talk about some compromises we can make there. But certainly for the examiner, you want the examiner to be comfortable with your arm relaxed so you can do this examination effectively. Patients who have reflux often have 1 million veins in their legs, and it's important to know which one you're looking at. And so the saphenous veins have some helpful features that I think are important. When we look at the great saphenous vein, generally it's within a little fascial envelope. Often this is the investing fascia of the leg, and this is a fascia of the saphenous vein. People talk about this being like the Egyptian eye or the eye of Horus on a transverse view. And this area here is often called the saphenous compartment. I think it's probably not a compartment, but people refer to it as that. The small saphenous vein lives in a triangular fascial space between the two gastrocnemius muscle heads and a more superficial fascia. And so these landmarks will help you be sure that you're looking at the saphenous trunks rather than some branch or tributary. So location's really important, and this is a nice cartoon that shows you, these are transverse views of a vein traveling through that saphenous sheath that I showed you earlier, and in transverse you see the vein sitting in these two locations. There may be tributary veins, and in fact the tributary vein may either be the place where the reflux goes or the main flow into the competent great saphenous vein, and you identify those branches because they're outside that fascial envelope. Sometimes, like in this case, the main trunk of the great saphenous vein has atrophied or maybe was absent, and all of the flow is going through a superficial branch. So identifying those things are really important. When we talk about branches, it's important to differentiate between tributary veins, or we often call them branches, but tributary is more proper, and perforator veins. Tributary veins are normally present, and they flow is normally from the tributary into the main trunk saphenous system. Perforator veins, again, normally present, and the flow is normally from the superficial vein to the deep system. So flow in the perforator is from superficial to deep. The largest perforator veins are the perforator veins of the saphenofemoral junction and the saphenopopliteal junction in most people. There's a lot of variations in the great saphenous veins. Surgeons like me identify this when we do distal bypass grafts and want to use the great saphenous vein as a bypass conduit. But there's lots of variations. The most common one being what's illustrated here, and that's more or less a duplicate system. The duplicate system, the more posterior vein may fill the posterior arch in the calf, and that could be related to perforator incompetence, and the more anterior one follows the more normal anatomic course. These variations are also superimposed upon common variations in reflux, and we'll get into some of this a little bit later, but here's reflux going down the great saphenous vein to a nest of varicosities at the knee. Here's reflux in the body of the great saphenous vein, not originating from the great saphenofemoral junction, but through pelvic or other collateral veins, and then down into the same nest of veins. And then sometimes there'll be perforator incompetence feeding the great saphenous and so on. Another finding we sometimes see is the medial branch of the great saphenous vein that may wrap around the back of the leg through the intersaphenous vein to produce reflux in the small saphenous system. So one of the most important things when we do reflux examinations is to very carefully identify the communications between the deep and superficial veins and the various tributaries and branches, and you really want to trace the reflux. Identify the sites where reflux occurs. Where did it come from? Where is it going? Is it feeding the veins, and is it coming from the saphenofemoral junction, a pelvic or other type of collateral or what have you? That information enables you to design the proper treatment for the patient's problem. Perforators, again, the nomenclature has been simplified, and I think there's really only 3 areas of perforator veins that are relevant clinically in most patients. There's the distal thigh perforators, which join the superficial veins to the femoral vein or the central aspect of the popliteal vein in the adductor region. There's paratibial perforators in the proximal calf that go directly into the posterior tibial vein. And then there's the posterior arch veins that go from the accessory great saphenous vein into the posterior tibial veins. There are also perforators on the lateral anterior aspects of the leg, but less patients have problems with those, and they're less commonly associated with ulcers and other complications, although they do occur. So when we look at an evaluation of the veins for reflux, there's some decisions the clinician has to make. How much of an examination do you want to do? What position will you do it in? You have to measure diameters, which ones, where, and so on, how to assess reflux, documentation, and then if the physician is not doing the exam, how do you delegate and supervise a sonographer who's a non-physician? I believe that you should have a comprehensive evaluation in anybody having reflux testing. So my view is that the entire deep system should be evaluated just as you would evaluate it for evaluating deep venous thrombosis or chronic obstruction, plus evaluation of the superficial veins, plus reflux testing. And that adds up to a big exam, but gives the picture that's necessary for the clinician to make the right decision for interventional treatment, if indicated. When we measure diameter, the question always comes up, longitudinal or transverse. This is an example of measuring the diameter, 3 millimeters in longitudinal view. I wouldn't recommend doing this. The vein should be measured in transverse view. Sometimes it's a little easier to do this because you can examine you can do the duplex evaluation with your pulse Doppler at the same time, but I think that you need to have a transverse diameter to be accurate. Generally, in a vein that's not been inflamed, it's not necessarily important whether you do inner wall to inner wall or outer wall to outer wall. as long as it's done consistently in your laboratory and you use consistent criteria in evaluating that. Depth. The depth of the vein is really irrelevant to the reflux, but it can be very relevant to the treatment. When we talk about endovascular thermal ablation of veins, if the vein is very close to the surface, that may not be a suitable treatment, and a better approach may be sclerotherapy or vein excision or something else. So generally, depending on the physicians you work with, the depth may be an important parameter or may not. Reflux testing, again, what you'd like to do here when you do this is you would like to use the physiological stimulus. Probably the best stimulus there is standing position, if possible. You need to do distal augmentation to produce forward flow in the veins and then assess for reflux. And so this cartoon here shows what you would expect to see in a normal leg. You squeeze the calf, you see forward flow in the vein. When there's venous reflux, you see forward flow, followed by refluxing flow. Different patient positions have been suggested, and we'll talk more about that as we go along. This is a nice summary from an article that, again, is not recent, actually is quite old, but points to the most important parts of this examination. And rather than go through this in tremendous detail, and again, I would recommend this article to anyone who wants to know the nitty-gritty about how to do this examination appropriately. I've translated this into a little more simpler version. Basically, the test should be done optimally using distal compression in the standing position, if at all possible. And again, that's not possible in every patient, but when it is possible, that's what you should do. You need to measure an observable endpoint for reflux. And the peak velocity of reflux is not a reliable metric. The most reliable metric is the time, the duration of reflux. We refer to this now as reflux time. In the past, we used to refer to it as valve closure. The meaning is roughly the same, but I think reflux time carries the right message. Manual compression can be difficult. Again, it depends on the patient, depends on the examiner. There may be some role for using an inflation device, and there's probably no advantage in terms of sensitivity or specificity, but it may make the examination easier and more consistent. What we know from the comments is that there are some things that are not so good. Proximal compression and Valsalva generally will produce findings, but they may not be reliable. There may be a lot of false positives. The supine position lengthens the flow reversal time in most limbs. It also decreases the vein diameter naturally, and that may have an impact on a number of things we'll talk about later on. Color Doppler is sometimes used by some labs for reflux, but is really not quantitative, and you can't assess reflux duration that way. So in my view, Valsalva, color, these are things that you shouldn't rely on as standards. So again, I mentioned before, the patient standing is probably the best way to do this exam. A patient should stand on the contralateral leg, so the examined leg is relaxed, relaxed muscles. This gives maximum venous dilation and natural gravitational effects on flow. And the examination should be done with pulse Doppler, abrupt compression and release, and again, no absolute advantage to compression, but I think it can be helpful. So this is what you would see in a reflux examination. This looks just like the cartoon I showed you before. Here's the distal compression happening here, and here's the reflux. Here we've measured the reflux at 1.6 seconds. Now again, various labs and various publications will talk about different ways of doing it and various compromises that you can use in the obese patient or the patient with arthritic disease or someone who can't stand. And I think it's important to recognize that in many of these cases you'll see false positives. And I find that many of the patients we have that are obese, we often have to use a combination of reverse Trendelenburg and seated with the legs dependent. This will give a reasonable examination, but not an ideal one. To do these examinations, you don't need complex equipment in your lab. For patients who have good balance, this is a good device. A more stable platform like this is useful. And here's the chair where you sit so you can be comfortable during the exam. This is an illustration of a patient who probably does not have a reflux, having a venous reflux examination. Again, showing the examiner in the seated position here, comfortably examining the patient's legs. You can do reverse Trendelenburg with a standard stretcher like this. I find most patients slide right off the table when you do this, and that's kind of embarrassing. A tilt table, like you would have in a cardiology lab, can be very useful, and some radiology labs still have tables like this available. The most important component of this device is the footrest. So you can get the patient up at 30 or 35 degrees, and it's almost like a standing examination in that they put their weight on the contralateral leg. I mentioned that the criteria for reflux are dependent upon reflux time, and there's a lot of variable things that you'll see in the literature. I think the criteria that I think are most specific and for meaningful reflux are these. These come from Nikos Laprodoulos. Again, these are not from a recent publication, but these are, I think, very valid and are used widely both in the United States and around the world. 1,000 milliseconds for the main deep veins, 500 milliseconds in the great saphenous trunks, in the profunda and in the calf veins, and then something around 300, 400 for perforator reflux. Perforator reflux is hard to evaluate. Perforators are often not straight, they're not cooperative with examination. So many investigators will recommend just measuring the diameter. If the perforator vein is not more than about 3 millimeters in diameter, it's probably not a significant perforator. And some authors will say use 500 milliseconds for all of them. And some of the criteria obviously depend on what position you have the patient in. Here's a nice example of some reflux, but something's missing. What's missing here, of course, is using calipers to actually measure the duration of reflux. This is a greater than 6-second sweep, so I think you can feel confident that this is prolonged reflux. But in the United States, this has to be quantitated if you want somebody to pay for your study. And so here we actually quantitated it. So this is a greater than almost 5 seconds of reflux in this vein. Perforators often look like this. They're squiggly. They may have bidirectional flow, and so measuring actual flow in the vein and looking to use the spectrum for documenting reflux can be challenging because of the anatomic configuration of the vein. So again, I think a lot of labs, including ours, really rely on diameter measurements. And this is just an illustration of that. So here's this is a perforator. Here's the superficial vein. The perforator vein is here, and this is a measurement of diameter. We try to do these in transverse, but again, with the tortuous perforators, it can be quite difficult. So you've done the exam, you've done all these wonderful things, and you've been very meticulous about it. Well, how do you put all that information together and communicate it to anybody in a way that they can understand? And that's a big challenge, I think, unless you're prepared to write a treatise that no one will read. An illustration is often the best way to do it. And this is an illustration from a friend of mine in St. Louis of what they use there. And this shows a pattern of reflux I showed earlier with reflux from the saphenofemoral junction along the deep reflux and then coming out through a perforator vein into varicosities in the proximal calf. So this kind of a reporting system is good, but the point here is that I think the lab that's doing the examination needs to know their customers, needs to know who the surgeon or phlebotomist or whoever it is they might be working with, what they need to know, how they need the information. Structured reporting can be very helpful in this regard. So in the United States, we have mostly sonographers who do these rather than physicians, and whenever we tell them that we want to do a reflux study in a morbidly obese patient with a giant ulcer, this is the reaction we get. This is unhappiness. But this just springs to the idea of training and who ought to be doing these exams, what do you need to know, and so on. And I think these are some useful comments from a radiologist published, again, not recently, but this is a problem that persists. And I think from this talk that we've given so far here, looking at the variance in anatomy, the various patterns of reflux, the complexity and detail work that's required in documenting the reflux in a way that's going to be meaningful for the treating physician, that's not something that every non-physician sonographer can do. And that's no knock on non-physician sonographers. It's a reflection of the type of examination we're talking about. A physician sonographer is good, but we physicians tend to get focused on what's important to us rather than a comprehensive exam. So sometimes physicians get off base too. So education and training, I think, is important regardless of who's doing this examination. And of course, the most important thing is communication with your referring or collaborative team. And in the United States, there's numerous programs for accreditation of vascular diagnostic facilities. And I just wanted to show some things here. Again, so a lot of verbiage, all in English, but these are standards from the Intersocietal Accreditation Commission, which accredits vascular non-invasive testing labs in the United States. And they have explicit standards for reflux, and they describe all the things we talked about: assessment for obstruction, reflux, calf muscle pump vein mapping, and so on. And they recommend that there be proper maneuvers to assess retrograde flow and reflux. Patient position should be noted at least on the examination. They say 15 degrees because they're pretty nice, but I think that's probably not sufficient degree of elevation for most patients. And they go into what aspects need to be documented in terms of grayscale. So this is grayscale images of common femoral and so on. You can see the various veins with additional images added whenever you see pathology. And the same thing when we talk about spectral waveforms to assess the degree of reflux. And they also specify that reflux should be measured using calipers on the duplex spectrum. We also have many insurance companies and other payers in the United States who are very insistent on appropriate documentation for payment for these services. And this is just an example of one of the payment policies. Anyone with interest in this, and I assume that no one here has interest, but if you do, there are websites for all of our insurance companies, and you can look up all the policies that pertain to this, and their ones for venous reflux treatment are quite specific. In the States, it requires that the people doing the study be credentialed, primarily to make sure that the examination is conducted in an accurate and responsible way, and that there are not false positives that would lead to treatment that might not be necessary or beneficial to the patient. So there's requirements for either accreditation of the laboratory or certification of the actual sonographer doing the test. So this is just an example. Some of the payers, depending on their policies, may insist that the refluxing vein be at least 5 millimeters in diameter, or they will not pay for the intervention. Some will have specifics regarding how long the reflux is. And some will insist on 1 second reflux rather than the 500 millisecond number. And so this is an important consideration in the United States. Payment is not why we do things right, although for some people it may be. But I think it's very important to remember that the components of this examination are critical to treating the right patient the right way. And so, in summary, I'd just like to say that I think that you really need to understand the venous anatomy and the variants, the pathophysiology of reflux, both the basic valvular incompetence, and the various patterns of reflux from the deep system to the superficial system through the perforators and so on. Very important to understand that. And follow the reflux, cherchez le reflux, as they say in France, and consistent criteria, clear documentation. Thank you very much.